So today I am going to present on functional neurology. This is something that I've been studying since I was in chiropractic college, and it's something that I hope to implement in practice down at the chiropractic clinic, but also, on an institute level. So before I get started, just a little background about myself since most of you don't know me. I'm pretty new here still. I have a bachelor's in science from the bachelor's in neuroscience from the University of Michigan. From there, I went on to get my doctorate in chiropractic from Life Chiropractic College West out in the Bay Area of California. While I was out there, I began my postdoctoral studies in clinical neuroscience through the Carrick Institute, and I hope to sit for the diplomate test this fall in October. This is just the certification process, or one of the certification processes for the clinical neuroscience program. So why I got into this field is it's kind of important and goes along with my background, where I come from. Just to make like a long story short, my first exposure to chiropractic was when I was working at another clinic in Flint. While I was there, I was a chiropractic assistant. I was in high school, so I kind of didn't really know what I was going to do yet. But while I was there, I got to see a lot of amazing things with chiropractic. And also, we had a functional neurologist on staff. And while I didn't even get to see the many things that I've seen now through functional neurology, I did get a little taste of what is possible. And that was really exciting to me. At the same time, I was a kid that grew up with chronic migraines. I had been in and out of the whole medical system, so to speak, seeing all kinds of specialists, neurologists, optometrists, kind of everything, tried everything, even traditional chiropractic. Nothing really seemed to kind of take the edge off of the migraines for me until I started getting functional neurology care myself while I was in chiropractic college. That was kind of what sealed the deal for me, and also kind of solidified why I was studying this and why I wanted to be this kind of practitioner. So I want to start off with a quote. This is a quote that I've heard bounce around a few times while I've been doing my studies. It's from Charcot. It says, "Let someone say of a doctor that he really knows his physiology or anatomy, that he is dynamic. These are not real compliments. But if you say that he's an observer, a person who knows how to see, this is perhaps the greatest compliment one can make." So this quote just kind of relates to our training in functional neurology. We're trained to be observers, and above that, unbiased observers. Because at the end of the day, it's really difficult to address signs that you can't see. So when we're going through the program, it's all about, observe, observe, observe. Try out a therapy, retest it, and observe. A lot of times we tend to miss those subtleties, those nuances that really can give us a good window into what's really going on with a person. These are kind of those, we're kind of taught to be detailed oriented, so to speak. So what is functional neurology? Functional neurology is just a way to diagnose and treat functional or physiological brain imbalances. We use these treatments to improve the brain, the nervous system, and just kind of this overall physiology of a person. We use the same basic principles of neuroanatomy and physiology that neurologists use or any other practitioner, but we use what we know about the neuroanatomy for therapy and rehabilitation, and we do this through different brain-based exercises, and I'll kind of get into that a little bit more later on. But basically, one of the earliest things that we're trying to diagnose or identify when we're looking at a patient is the earliest signs of neurodegeneration. And really, this is just fatigue. And this is different from metabolic fatigue in that, the person's tired all the time or they're tired for no reason. This kind of fatigue that we're looking for is people that are fatigued after they do something like drive or read or do some sort of simple math, something that requires brain power, and this is tiring them out when it really, it shouldn't. Now, certainly we work with people that are, much more further advanced than this in whatever neurodegenerative process is going on. But, we know that once a person's got a tremor, in Parkinson's, it's too late. A lot of damage is done. It's hard to go back. While we can certainly help improve the function of this person and improve the quality of their life, it's really hard to undo a lot of that damage that's already been done. So we try to attack it as early as possible. And really, we're just investigating how the nervous system is functioning overall. So a lot of times, too, in neurology, we're looking for ablative lesions. We're looking for things that, you can see on diagnostic imaging. In functional neurology, we're looking for things that are not necessarily visible on any kind of diagnostic imaging. We're looking for physiological lesions, things that are non-ablative. And I'll kind of get it more into that when we kind of go into some of the concepts of functional neurology. So who do we help? Really, we can help anybody, all kinds of patients. Functional neurology can be applied to any case, really. But right now, what are some of the hot topics or hot cases, so to speak, in functional neurology are kind of on this list? So post-concussive syndrome, some of that brain fog that goes on after a concussion or a traumatic brain injury. We work with all kinds of movement disorders, so Parkinson's, dystonia, tics, things like that. Neurodegenerative disorders, vestibular and balance disorders, vertigo, neuropsychological conditions, people that are battling PTSD, depression, obviously pain syndromes, migraines, which I have a passion for personally just because I empathize with these patients, developmental disorders, and also we work with a lot of elite athletes or just athletes. I just was at a conference and the hot topic was the overall topic was on performance and how we can enhance human performance. So we're even using this in people that aren't necessarily suffering from something, but they want to get better at a skill. So functional neurology was founded by this guy. His name's Dr. Carrick. He is a chiropractor by trade. He comes from Canada, but he primarily works now down in Florida, Atlanta. And he's really the guy that's pioneered this whole career and field of study. He's been working on this for over 30 years. He's been published in tons of articles or journals, that whole list right there. And really, he's just one of the most amazing docs I've ever had the pleasure to watch work in action. He's a master at neurodiagnosis. He's so humble. He really connects with patients, and you can really tell that his patients feel like he's listening and that he can offer them real solutions. And so it's been a pleasure to learn from him over the past few years and the whole Carrick staff, really. And then, of course, that's me with a picture of me with Dr. Ted Carrick himself at a conference that I just attended in Orlando, the one that was about human performance. So it was at the IINN, the International Symposium on Clinical Neuroscience. This is kind of the once-a-year conference where all of us neuro nerds, all of us diplomates kind of can get together and talk about what's the cutting edge research in neuroscience and clinical neuroscience. So it's a lot of fun. So I'm just going to kind of go over some fundamental concepts that we like to talk about um, in functional neurology. These are kind of concepts that are absolutely necessary to understand, some of the more deeper things we go into and understanding why some of these things are happening in patients. So I'll just kind of go over each of them briefly. I won't spend too long on it because I don't want to bore you guys. But so anyway, the first one, central integrative state. So this is just the total integrated input received by a neuron or a group of neurons kind of at any given moment. This is kind of the measure of what the metabolic capacity is of a part of the neuraxis. So what's the central integrated state of the spinal cord or one particular group of neurons. So it's kind of important to understand this, especially when we're assessing people and we're assessing to see, where they are right now. Well, how stable are they? Transneural degeneration. So this is a pretty big one. And this kind of works off the principle of neuron theory. What does a neuron need to be happy and healthy? And we know that a neuron needs three things. It needs adequate glucose, adequate oxygen, and adequate and appropriate stimulation. If it's lacking in one of these three things, then we're going to start to see that neuron stop producing the proteins that it needs to make, and we kind of start to just see it shut down. And eventually we can see it degenerate. So understanding this concept of T&D is really important because it can help you, figure out what your method of treatment might be with somebody. And it kind of also helps play into that whole physiological lesion. Somebody doesn't necessarily have a sever of a nerve or something, but they've got this T&D happening in that whole nervous pathway. And what are we going to do about it to fix it? The next three, frequency of firing, time to activation, time to fatigue. Again, these kind of go along with the neuron. When we're doing certain tests, for instance, when we're looking at pupil dilation, we're looking to see how fast it fires, how long it took for it to contract, and how long it takes for it to fatigue out. We want to see things fire really quickly, respond really quickly, hold their activation for an ample amount of time before it fatigues. And again, these are signs that can help you decide, okay, where is this physiological lesion? And in early T&D, we're going to see this shorter duration of the firing. We're going to see a slower time to activation. We're going to see fatigue early. Diaskesis, however you want to pronounce it. This is just a degeneration of neurons downstream from it, basically because it's lost its responsive stimulus from the neurons upstream. So again, in T&D, if we're not producing those protons or those proteins in that neuron, what it's necessary to keep it going, we're going to start to see this diastasis downline. If one neuron stops firing, we're going to see everything downstream from it, kind of have a weakened response as well. Because we know in the nervous system that, it's a chain. One thing, neurons that wire together fire together. So if we've lost a neuron in that chain, then we're going to lose the signal. Neuroplasticity. This is huge. This is why we're all sitting here. This is why we can all walk and talk. This is our ability of the nervous system to learn. And really, this is what functional neurology depends on, is the ability for our system to make these plastic changes. If we can't do that, then we're not really going to get too far with somebody. And again, with neuroplasticity, there's bad neuroplasticity and there's good neuroplasticity. And obviously we're trying to emphasize the good neuroplasticity and rebuild those pathways that for whatever reason are under demise right now. Homologous relationships. This is super important when you're trying to decide what part of the neuraxis isn't working and how you can tap into that part. If you know what parts of the system are from the same embryological tissue, even though when they when we grow, they differentiated, they're still connected. So we can use that information to tap into certain parts. Excitation, inhibition, this is just kind of the, knowing what systems are excitatory, what's inhibitory, what inhibition of inhibition means, things like that. Neurological windup. So a lot of times in patients, we'll see that they're very fragile. They're very close to threshold, I like to say, which really just means that they're in this hyper excited state of activity. And this can be due to a couple different things. They've got this overactive activation of their MDMA receptors because they've got a lot of calcium rushing into the cell, or they've got a lot of free radicals floating around from excess anaerobic energy production, or they've just simply got some TND. But you'll see these people where any little stimulus kind of just sets them off. So again, it's important to identify these signs in people because, when you're doing a therapy, you want to decide, is that the appropriate therapy at the time? Is this going to feed into, the brain the way we want it to? Or is it going to be too much and we're just going to undo all the work we just did? So we work our way up to what a patient can handle metabolically. I kind of already talked about ablative and physiological lesions, so I won't go through that. Longitudinal level of the lesion. Again, we're just trying to determine what part of the neuraxis isn't working properly. Is it an end organ? Is it a peripheral nerve? Is it the cord? Is it the cerebellum, the brainstem, the basal ganglia? Is it the cortex? What lobe of the cortex? So we're kind of just trying to narrow it down so that we can narrow our focus. Knowing cortical input and output, what are the pathways? It's crucial to know these pathways. This is kind of example of one pathway on the screen. This is how the cortex plays out into the autonomic system. Again, this is super important stuff to understand. If you don't know your pathways, then you're kind of SOL. And then neuroanatomy, again, just knowing the lobes of the brain, the cord, what does it look like structurally? This is important. So I'm going to go over a couple studies. So the first study is kind of our early beginnings study. So this was a study that Carrick did back in the 90s. This was kind of the very first study that kind of demonstrated that what we do as chiropractors, as functional neurologists, has an impact on the brain. And this is, cool, really cool stuff. So essentially what he did with a patient was he, had them stand a foot away from the wall. He had them, look straight at the wall. He took a pen or something that, they were supposed to see in their field of vision, brings it out to the side, and he asks them to say, okay, when do you stop seeing it? When do you see it again? And you kind of just map out this blind spot. And now, normally you should see that blind spot be, kind of tight, like the size of a quarter, and even from side to side. Now, obviously in this picture, we see that one is way larger than the other. And this larger blind spot is the pathological blind spot. And this basically just indicates that we might have some sort of demise, maybe that's kind of a harsh word, but we have some dampened cortical output that supplies that physiological blind spot. So that blind spot we know is going to connect to the opposite side of the brain. So then he took these blind spot maps and then he just decided to do a simple therapy. So depending on whatever side the blind spot was on, he manipulated that side of the cervical spine or the neck, and he just remapped it, retested. And what he found was that he could get the blind spot to decrease in size and kind of even out from side to side, which was really cool. Again, this just kind of demonstrates that, you know, if we put a stimulus to force into the body, we're going to have a cortical consequence, and that's going to make a change. Um, we still use blind spot mapping. You know, it's not something that is necessarily 100% precise. There's a lot, you know, can be some user error with it, but it's a cool and easy test to do with people, and it's actually a really great learning tool with patients because it's something that they can see. It's something tangible. So it's just a cool beginning to where we are now. So this next study is kind of the most recent study. This was put out last year. This was kind of exciting. This was a paper done on stroke patients where we had a control group that just received 125 milligrams of aspirin a day, just kind of standard post-stroke protocol. And then we had the treatment group who also received the aspirin, but also had a specific eye movement therapy given to them that they did for so many days. And basically the eye movement therapy, you'll see it on the next slide, it was just given to them specifically based on whatever side the stroke was on. So if the stroke was on the left side, then the eye movement therapy was in one direction. If it was on the right side, then it was in the opposite direction. And this was just kind of to target that cortex that had some damage, ischemic damage from the stroke. So on this side, so this is the video that they used or similar to it. Again, this is for a patient that would have had a left brain or left-sided stroke. So what you're going to see is this red dot moving up the screen. It's doing these saccadic movements. So these are just quick eye movements where you're going from one target to the next, and it's moving up and to the right to target that left cortex. And then once it hits the top of the corner, you're going to see that then the red dot's going to just slowly come down to the bottom left corner in a pursuit fashion. So this pursuit mechanism is going to tap into the left cortex, left parietal lobe to be exact. We kind of know that certain eye movements in certain directions correspond with different parts of the brain, and we can use this advantageously in our therapies. So saccades are typically connected to the opposite brain or opposite frontal cortex, contralateral cortex, and then pursuits are typically connected to the ipsilateral parietal lobe. And then this direction kind of also targets the cerebellum that's also connected to this whole mechanism here. So just a really cool paper. They saw a very significant increase in function in these patients that received this eye movement therapy. And now this isn't anything new to the Carrick Institute or Diplomates. This is a type of therapy that we've been using for years. You know, we don't just use this on stroke patients, we use this on all kinds of patients. So, but it's cool to finally see this published in a study, and hopefully we'll start to see more papers, more and more come out that, you know, and that are related to other types of conditions and can really demonstrate all the good work that we can really do with these people. A couple more articles. I won't really go into these, but the top left article, this was put out by Heidi Habig. She's not necessarily a functional neurologist, but this was a cool study because it was kind of one of the first studies to actually measure with an EEG, a QEEG, that when you manipulate a joint, that it's going to light up part of the prefrontal cortex. Again, this is super cool because now we can actually measure and show, okay, what we're doing does have an effect on the brain. This next study, posturographic changes associated with music listening. When I kind of go more into the therapies, you'll see we use all kinds of different tools and techniques. You know, we might put music just in one ear to stimulate the vestibular nucleus, things like that. And then we, measure out their posterographic sway on um, a surface that measures the sway. We'll see that in a little bit. Just really cool stuff. And then the bottom study, this was something that they did in veterans that have PTSD from blast injuries. They did the same sort of type of treatments that you saw post-stroke, a couple other different types of therapies, and they wrote a paper on it and demonstrated, the awesome results they were getting with these patients. Better results than the leading drug out there for PTSD. So it's really cool. We can help all kinds of people. So we have this range of diagnostic and therapeutic techniques. Diagnostically, we obviously the history is huge and important. In school they always used to tell us, your history gives you 90% of your diagnosis, and it's just vital to really sit there and listen to the patient and understand their whole makeup. When I went and had functional neurology care, my history portion probably took a half an hour or 45 minutes for us to talk about, but it was the first time that I had ever felt like a practitioner really understood my entire case. And they had asked me all kinds of questions I had never even thought about being related, but as soon as they did, I was like, oh my God, yes, that of course that relates. That makes so much sense now. So the history is huge. Obviously, we do a comprehensive physical and neurological exam. And then we have some different types of diagnostic equipment. That's pretty awesome. This video nystagmography, or VNG, if we don't want to say that word a million times. Basically, you'll see it in the picture here that you just put the goggles on a patient, and what it does is it records and measures their eye movements based on a target on a screen that we might have them watching, and then it plots it out to what should be the normal movement for those eyes, and then you have a real objective, quantifiable measure of what's not working with this patient. So you don't necessarily need this type of equipment, but it certainly is helpful and beneficial to have, because it really helps you determine, okay, what exactly isn't working, and then you can retest and see what changes you are making. Posturography down in that left-hand corner, so you can have these different platforms. Patient will stand on it. It'll measure their sway, like when they do a Romberg's or like a one-leg stance. Then you can put them on a perturbed surface or like a cushion, again, and measure that. And again, this is just good to have objectifiable measures here. We look a lot at gait and movement. This is huge. And of course, functional neurology isn't functional medicine per se, but there are a lot of functional neurologists that do a lot of functional medicine type work with their patients. So we might run lab work, because some of these people, they're deficient in something. They need some sort of building block before they're ever going to get better. So it can be advantageous to run some panels on these people and figure out, okay, what do they need? And address that with, a different type of, a certain supplement, or, Therapeutically, of course, most of us are chiropractors by trade. Not all of us. Functional neurologists can be medical doctors or nurse practitioners or physical therapists. It's kind of more all-encompassing than just chiropractic nowadays, but a lot of us are chiropractors, so chiropractic manipulation is certainly our most powerful stimulus into the nervous system. So we might, adjust on a certain side, or if that patient can't handle an adjustment, to the upper cervical spine, maybe we start distally. Maybe we start with some finger adjustments, or we start with some fast stretches of muscles. Eye movement therapy, kind of just like that video we saw a few minutes ago, we have all kinds of programs where we can build different types of eye movement therapies. Pursuits, saccades, we can have them do OPKs, all kinds of things. I've even spun people in chairs before and done eye movements that way, where you're working in their VOR at the same time. neuromuscular re-education, so we might have to reteach somebody how to move. We might have to, do some mirror box therapy where, they're looking at the good arm moving and then tricking the brain into thinking that the bad arm, it can move that way, so to speak. Non-invasive nerve stimulation, people will get these little galvanic stimulators. You can place like an electrode on a tongue or on the tragus, and we can stimulate, a certain cranial nerve and therefore a certain part of the brainstem to stimulate whatever part of the brain we're trying to work. Interactive metronome, again, this is a really cool thing. I got to play around with this past weekend. So the patient will have a set of headphones on, they'll have this auditory stimulus, they'll have a little button in their hand and they have to clap on the beat. And they'll also have a visual stimulus. And for instance, the one that I was using, it was like you were golfing. So if you hit the target, if you hit the button right on the sound at the right time, then the ball would go straight. If it was too slow, it'd go to the left. If it was too fast, it'd go to the right. So it would give these patients a visual feedback. Okay, are they on target? Are they on beat? The Dynavision you'll see on the next page. The multi-axis rotational chair you'll see on the next page. So this bottom picture here, that's the gyrostim. They've got these at the brain center. So these are, they'll put patients in these and they'll rotate them at certain pitches and yaws to activate certain canals of the vestibular system. This is some really cool stuff. Obviously, we don't have one of those here, but when you've got patients that are a little bit beyond what you're able to treat, we've got these other centers where we can send them to work with these practitioners that have a little bit more knowledge, working with these, more advanced cases, and then they can do some intensive therapy with them for a week, and then they can send them back to you, and you can monitor and keep working with those patients. Up in the right-hand corner there, that's the Dynavision. So this is, a piece of equipment where these buttons will light up and you can have them go in certain patterns. You can have it be in a certain, field where they have to go to a certain area. You can have them, only hit, with their right hand if it's one color and the left hand if it's another color. So you can do all these different kinds of patterns. And then the picture below it was Steph Curry. It's kind of the same idea. You've got these targets that the patient has to hit. The thing that's cool about those ones on the bottom is that those things can move and you can put them on, like with an athlete on a net where they have to like hit a certain part of the net before blocking a shot. The kid with the headphones, that's the interactive metronome. And then in the top left corner there, we've got the Focus Builder, a picture of the Focus Builder app. So this is an app that I use that I can build my eye exercise programs on for a patient. And then we can make it specific to them. I can record it and I can send it to the patient and they can use it for themselves.
His method.
Oh, so I forgot that was my last slide. So those are some of the therapies. Before I end today, I'm just going to play a short clip that I like to play for people that don't really know what functional neurology is. This is a Dateline special of Carrick. It's something that we just used to show when I was running the neuro club at functional neurology, the neuro club at my school on functional neurology. We'd show this to new students to kind of get them excited about it. I think it's just a good clip that kind of shows Carrick in action and shows what we do. You're going to see two cases in this video, one of a young teenage boy who suffered a concussion, and one of a mom who's has balance problems. And so it's just a good clip. So hopefully y'all enjoy it. I'll take any questions at the end after it's over. But just thank you for your time, and I hope that you got something out of this.
His methods are unorthodox. His critics are many, and yet a waiting list full of hopeful patients believe that one man has a miracle cure that can help them reclaim their lives, while alternative treatments for debilitating diseases are not a new concept. One chiropractor's unusual brand of surgery-free healing has made a major splash, and ABC's Juju Chang went in for a closer look.
And you play other sports besides lacrosse? You play hockey as well?
Yep.
Will Arlen has a traumatic brain injury, and he's so sensitive to light he wears sunglasses all the time.
How's your appetite?
Good.
His family believes this doctor holds the key to a miraculous cure. Ted Carrick is a chiropractor by training who specializes in the brain.
That's what I want to say. Okay. Let's take your glasses off. Have to do this stuff. And just sort of look at my nose if you can.
The 17-year-old describes his migraines like a knife stabbing his brain. He can barely stand up on his own.
I let go of you now.
And he has trouble moving his left arm.
Let's have you just come up and just walk over to that platform and then come back here. Just walk as you would normally.
It all started with a vicious hit during a lacrosse game. The severe concussion sent him into an 8-month tailspin. Tell me what the downward spiral was like.
Well, he was a pretty active kid, straight A student normally, and outgoing and all that. They had to pull him out of school again a couple weeks ago.
It's here at Life University in Marietta, Georgia, that Carrick is a pioneer in a field known as chiropractic neurology, a treatment he's been perfecting for 33 years. When hockey superstar Sidney Crosby suffered serious concussions, he praised Dr. Carrick for saving his career.
Let me see you do it on your own.
Carrick says it's all about reactivating pathways in the brain by stimulating parts of the body. Is this a miracle cure?
Well, I think miracles are things that only happen once in a while. And what we find is that the miracles that we see, we're seeing them frequently, every day. So they're not really miracles. What we do is amazing because of what humankind can do.
Can you see your left hand there?
In this exercise, Carrick uses a full-length mirror on Will to trick his mind's eye with his own mirror image of a healthy arm in order to reprogram his brain.
I want you to lift your hand up all by yourself now, your left hand. Lift it up.
A few minutes ago, Will couldn't lift his left arm without help. But now, this. For Will, it's huge.
Okay, good man.
But the big gun in Carrick's arsenal is this machine, which looks like it belongs to NASA.
Looking good.
Carrick says the gyrostim helps stimulate parts of the brain that may be damaged.
I realize what I noticed is like my breathing feels like it's not as shallow anymore.
Good. You're starting to breathe better.
Were you skeptical? What did you think coming in?
I'm very skeptical, but the thing that really sold me was the first day we were here, is watching the passion in Dr. Carrick's eyes.
He's got a big heart.
Critics say Carrick's results don't pass scientific muster, and his success is often dismissed as placebo, meaning the patients feel better because they believe in his cure. How can you be so sure that it's not a placebo?
Well, if it was placebo, we're doing a pretty darn good job of it. We don't do anything that is really original in our work. We just combine things that other people have done in a different fashion.
Yet despite the criticism, most of Carrick's patients are referred to him by neurologists, and he says he has a months-long waiting list.
Turn around and come back to me.
Stacey Hubbard traveled over 900 miles to find out why she can't walk more than a few steps without stumbling.
Tell me what you feel.
I am a dizzy, unbalanced mess.
A hands-on mother of two, she barely got out of bed for 10 long weeks.
If you could pick one thing, what's the worst thing that you'd like me to fix for you?
I want to be able to hug my kids after school.
Okay.
I want to greet them at the door.
Okay, let's go.
You did these arm movements, and you reprogrammed her brain? Is that fair to say?
Absolutely. And it happens very, very quickly. I look very, very carefully at what's happening with her eyes, with her head, the degree that her pupils are open or closed, and then her ability to track. And we find that if we do a certain motion and we get a different tracking, we say this is going to have a good probability of working.
Stupid floor. This is my problem today.
Over time, Stacey conquers her biggest enemy, the pattern on the hall carpet.
I think I got this hallway today. Yes. I totally did it. And I'm excited.
It's day 3 for Will.
I've been happy since yesterday for the first time in a while, so I mean, it feels good to definitely have someone who knows what they're doing. Is that why I don't have the feeling in my left side?
Yeah, I mean, it's pretty significant so that if your brain doesn't know where your hand is, it doesn't control it.
For Will, just doing that with his fingers is the first glimmer of hope.
Nice, eh?
Oh my god.
Okay. Let me see you walk. Swing your arms like a soldier.
and he's even able to swing his left arm.
That's huge, Will. It's huge.
It's a lot looser up there.
Yeah, it's huge. It's huge. It's huge. Okay, show me off. Go, go, go.
On average, the week-long therapy costs $5,000. For Stacy, it's worth every penny. When she gets home from the clinic, she's finally able to hug her kids on her own 2 feet.
These are the glasses I used to wear 24 hours a day.
And Will, who couldn't tolerate any light, is now able to get around without sunglasses.
Never mind concussions. How can we save his hair?
No longer on the sidelines, Will is slowly getting back in the game.
It feels good to be back on the ice.
I'm Juju Chang for Nightline in Marietta, Georgia.